So, Dr. Lama, thank you for joining us and for sharing your experience in amending the international guidelines and recommendations for CML therapy to reflect the local needs that you encounter in Nepal. I'll start by asking you, at which stage of the disease usually diagnosed in Nepal?
Well, I mean, the world has a data, the CML, the CP, the chronic phase, we have about 90% diagnosed, and then the rest of 10% is in the accelerated or blast phase that we encounter.
Okay, and tell me, in Nepal, which scheme of TKI therapy can you use there? The first, second, and eventually third line therapy? And is this available for all of your patients?
Yes, we have protocolized imatinib as a first line to start with any patients in a CML CP. So, but then if this patient land up in accelerated phase, we may start with second generation as well. But then the algorithm is we start with the first generation's TKI. Then if these patients are not responding or intolerant, then we move it to second generations, and then finally to the third generation. And yes, all these drugs are available in Nepal. So all these FDA approved TKIs for CML are available in Nepal.
That's good to hear. And how do you make decisions on switching therapy, and what determines your choices?
Well, first thing is the intolerance to the TKI that the patient is on board. So that is our first thing. And another thing is when these patients are doing okay with the therapy and then they lose a kind of a molecular response, then we assume that it is probably the resistance that patient has developed. So we go for a mutation analysis for those patients, and depending upon the mutation analysis, we will switch the TKIs. But there are certain instances that patient cannot undergo this mutation analysis. In that conditions, what we do is we just go ahead with the empirical TKIs, but we will also consider their comorbidities conditions, like if these patients are having a cardiac problem, then probably we try to avoid nilotinib and ponatinib in these cases. Those with liver dysfunctions, we probably avoid bosutinib and nilotinib. And yeah, so with the respiratory problems, we probably avoid dasatinib in these conditions. Yeah, so that is how we choose the TKIs for the escalation.
Thank you. So how frequently can you monitor the patient's response to TKI therapy?
Well, with the algorithm, what we do is we usually do the molecular response, that is RQ-PCR for BCR every 3 months. And for at least 2 years, then depending upon their response, if they are good, then probably we switch it to 6 months or once a year. For 2 years, that's possible because the government of Nepal is providing about $800 at a one-time incentive for the patient. So with this money, we can monitor this BCR-ABL for at least 2 years. And after that, then there arises a problem with this low socioeconomic patients. Yeah, so that's how we monitor patients. Most of the patients we are being able to monitor as a regular basis, but there are few patients where we cannot do all these things.
Tell me, are you trying to implement a TKI discontinuation program?
Yes, this is the latest thing happening in the CML. And fortunately, we have about 1.5% of the patients in a TKI, and there are about 2 patients who are already more than 10 years in the treatment-free remission. This initially we didn't have a data how we go about it, but then probably 10 years back, it just happened by a chance that probably these patients did not follow up, they lost a follow-up, or maybe the patient got pregnant and then like we had to discontinue with the TKI. And while on a monitoring, this patient were still in the major molecular response, or some of them were in a deep molecular response. So we just continued with this without a treatment, and then they were able to continue without the medications. So these patients somehow came into the treatment-free remission. Now we have a data on how we go ahead with the treatment-free remission. So yes, we practice that treatment-free remission. Yes.
What do you feel the biggest challenge is in Nepal to implementing the international guidelines and recommendations to the full extent?
Yes, this is a big challenge. Yes, the number one is like the duration itself. Like initially when we thought treatment is gonna be for lifelong. So that is the number one problem. And another thing is the accessibility of medications to the patients, as this is like a landlocked country, and I mean, because low socioeconomic people are more in this country, and people are living very far away from the center. So there are few patients who travel about 4 days to get to us to get this TKI. So that's how it happens here. And another is like I said, a financial constraint. The money that government is providing is enough to monitor this a molecular response for a while, but then just to get this test, the people have to travel a long way to get it over here. So that's difficult. So probably the duration, accessibility of the medications, and the financial constraints are the 3 things that is hindering us to do all these international guidelines as recommended.
And finally, what is the single most important aspect of clinical management of CML patients in Nepal that you would like all newly qualified hematologists to know?
Yes, the CML is really, just to say, it is a good malignancy that responds well to the treatment. So the most important thing what I would recommend is that like patient educations about the adherence to the tyrosine kinase inhibitors and its regular monitoring, and the regular follow-up should be the important just to go ahead with this disease.
Dr. Lama, thank you very much for your time today. On behalf of the ICMLF, it's been very nice to share this time with you, and thank you for your contribution.